Okay, hello everyone. My name is Deborah Bell. Sorry for my hoarse voice. Hopefully, you can all hear me okay. Um, and I'm welcoming you to our second Cha-Chi-Ming seminar for integrative women's health. And today we're going to be talking about breast health. So I'm going to share my screen and do a little introductory presentation for you. So just a little bit about our Osher Center for Integrative Health. We are part of the Department of Family Medicine at the University of Washington. And we have a bunch of clinical services. We provide integrative medicine health consultations, integrative primary care, acupuncture, naturopathic medicine consultations, and massage. And we love our staff. And we are part of the Osher Collaborative for Integrative Health, which is an endowment from the Osher Foundation. And it's 11 international academic centers, and 10 of them are in the United States. And we are lucky as the University of Washington to be one of the last few that have been invited in. And these seminars are graciously funded by the Cha-Chi-Ming Endowed Lectureship. And you can see here that it's Sunlin and Priscilla Chow Foundation. And the hope is, again, through their philanthropy, to help to educate both the public as well as professionals in integrative medicine. So that's me. I'm the Director of Education for the Osher Center, and I practice at Northgate doing integrative primary care and at the Ballard Center doing integrative medicine consults. And I have been practicing for many, many years and have been chairing this committee for this year's Cha-Chi-Ming. Our first speaker will be Dr. Emily Godfrey. She is a professor at the University of Washington Department of Family Medicine. And as you can see, she's an affiliate of our Osher Center and also core faculty for UW Medicine, Family Medicine Research. She integrates lifestyle medicine, evidence-based lifestyle interventions into primary care, working to empower patients to set goals and make behavioral changes. She's authored many, many, many peer-reviewed publications in her career in reproductive health, patient-centered outcomes, and now is focusing her attention on lifestyle medicine. And she'll be talking with us about those modalities and how it aligns with our risk of breast cancer. Our second speaker will be Dr. Stephanie Wang, who is a licensed acupuncturist and naturopathic physician. She also specializes in integrative oncology and survivorship. And she did a specific residency for that. She focuses on whole person care and emphasizes accessible care and equity. And she has extensive clinical expertise in naturopathy, hot flashes, insomnia, stress, and cancer-related pain, and holds a dual degree at Bastyr in both naturopathic medicine and acupuncture medicine. And I don't have a slide for him, but I want to also introduce Dr. Iman Maj, who is still on the screen here, is the director of our Osher Center. He is a physician, integrative medicine physician and acupuncturist, and a great visionary and leader for our Osher Center, and very grateful to have him present for this seminar. And with that, we'll start with, a couple of other housekeeping things. We will not have the opportunity to have you enter questions in chat. We often have a very large group for these, and so it really isn't possible to navigate the chat. However, we will have a panel discussion with questions at the end of when both presentations are completed. And we really appreciate your participation. I also will put in a plug. We don't have a slide for it, but most of our big programs are only possible made through philanthropy. And if you have any interest or ability or desire to make a donation, through the Osher Center, you can find a way to do that on our website. And we appreciate your support, both with your attention as well as any financial support that you might be interested in providing us in the future. And with that, Dr. Godfrey, we'll let you move on.
Thank you for that, Dr. Bell. All right, so yes, I just want to say thank you so much to Dr. Maj, Dr. Bell for the invitation to speak for the Osher Center. I'm just so excited to be here today, and especially thank Dr. Bell, who I've worked alongside with for several years at the Northgate Clinic, and learning about how we can apply whole person care in general primary care. And so that is the perspective that I bring today. Um, my motto for this talk is knowledge alone isn't power, but applied knowledge is. And again, I'm Emily Godfrey. My pronouns are she and her. So I have no conflicts of interest to disclose, but I do want to say that I may use the term woman or women in this presentation, and it's intended to include cisgendered women and gender diverse individuals who may not identify as women, but still have female breast tissue. So I apologize in advance if I offend anyone with the word woman. Objectives, I want to just talk a little bit about the epidemiology of breast cancer, sort of risk factors we'll review, and then what are some lifestyle modifications that we can all take to reduce our risk of getting breast cancer. All right, so this is just a map globally. We can say that breast cancer pretty much occurs throughout the world. And the incidence is the new cases of breast cancer. And essentially, every minute there are 4 females who develop breast cancer, and 1 woman who dies from breast cancer. You can see the purple generally represents the high income countries. So there are more breast cancers being diagnosed in high income countries, but it's actually the pink countries that are suffering from more deaths from breast cancer. And here in the United States, unfortunately, there has been increased cases of breast cancer. And the thought is because of the excess body weight that we carry, as well as persons who are having children at a later stage in life. There are approximately 300,000 new breast cancer cases diagnosed in the United States every year, and it does differ according to race, ethnicity. And if we look at breast cancer death rate, it has actually dropped more than 40% since 1990. And this is due to advances in early detection and treatment. However, there are disparities. And so you see the kind of the bright pink line are the disparities of white women who've had a decrease, a marked decrease in breast cancer deaths. However, Black women have a 50% greater chance of death after being diagnosed with breast cancer, and Native American women have seen absolutely no progress. So there's still a lot of work to do here in the United States as it relates to breast cancer mortality. So I do want to mention that we have very good systems in place in the United States in terms of what is working well, is that we have mammograms. And when breast cancer is found early, more than 99% survive at least 5 years. And this is compared to only a third who will survive when diagnosed at an advanced stage. Generally in this country, breast cancer screening starts at anywhere between age 40 or 50. It depends on which recommendation you follow. The American Cancer Society recommends starting screening at age 45. The radiology teams tend to start earlier at age 40, and the U.S. Preventive Service Task Force, which tends to be a guideline that I follow as a primary care provider, recommends screening at age 50. In terms of the age to stop, most of the guidelines recommend stopping at age 75, but this isn't a hard stop. It just means that as a person who's seeking additional breast cancer screening after age 75, you want to have a conversation with your healthcare provider about the risks and benefits of continuing to screen after that age. So let's talk a little bit about risk factors. And please understand that I am, a very traditional physician in the sense that I've been practicing allopathic medicine for most of my career for the last 20 to 25 years. And when we think about, who's at risk of breast cancer, we have a number of models or calculators. And this is one example. The Trier-Cusack is the most consistently accurate breast cancer risk assessment model. And models are only as accurate in terms of what we enter into it. So what we ask about patients is age, right? This is a non-modifiable risk factor. And breast cancer risk goes up as we age. So the average age of breast cancer in the United States is age 62. So someone who's in their 60s is going to be at higher risk than someone in their 30s. We ask about family history. If there's been a first degree relative, either male or female parent, a brother, sister, or child, who has a gene mutation or not can be at higher risk of breast cancer. We ask about reproductive history, how early the patient started menstruating, whether or not that patient had children, whether or not they breastfed, and what age they were at when they went into menopause. And then, of course, a personal history of benign breast disease has also increased risk for breast cancer. And then there's a newer entity that goes into this model, namely the mammographic breast density. And having dense tissue identified in mammogram, which measures how much fibrous tissue or glandular tissue is showing up, can in fact impede the read of the mammogram. And someone who has very dense breasts are considered slightly higher risk than those who have more fatty breast tissue. And the density does not have anything to do with the size of breasts or the firmness of breasts. It's something that is shown up really on the imaging. And many patients come to me and they worry about their family history with breast cancer. And one thing I want people to understand is what's important to know that hereditary breast cancer, so having this BRCA gene, only accounts for 5 to 10% of breast cancers that occur in the United States each year. And in fact, it's 75% of breast cancers in women in the United States are average risk. They don't calculate as a high risk based on that calculator I just showed you. And so the key is to have breast awareness. Back in the day when I was a medical student, they talked a lot about doing a monthly breast exam, and we've moved away from that. But what we do want to encourage patients to have is awareness in terms of what's normal for them in terms of the size or shape or texture or their skin on the breast, the nipple, and even just the armpit area, and to be aware of your own body. And if you have concerns, to point that out to your healthcare provider. So, what can we do other than kind of some of these non-modifiable things that go into this calculator? And this is where I feel, as a traditional family physician, we really have not been encouraged or have learned how to speak openly with our patients about other things that we can do to reduce our risk for breast cancer. So it's certainly adopting a healthy lifestyle is a key strategy to reducing risk of breast cancer. One of the most important recommendations is to maintain a lean body weight within the normal range. And it's excess body fat, and particularly after menopause, that has been linked to increased estrogen levels, which can promote the development of hormone receptor positive breast cancers. So how do we achieve and sustain a healthy weight? So this diagram has a lot of different points, and I'm only going to highlight some of the ones that we do tend to talk about in clinic, which is being physically active every day. And that's more than 30 minutes, 5 days a week. And consuming mostly whole plant-based foods. So having more than 5 servings of fruits and vegetables per day, eating less red meat and really cutting out the processed meat, and also limiting your alcohol intake to less than 1 drink a day. And a drink means 12 ounces of beer or 4 ounces of wine. And if we implement all of these lifestyle changes, we can reduce our risk of breast cancer by up to 60%. And so for me, I think it's really important that healthcare providers emphasize how important it is to reduce our risk of breast cancer. So the bottom line with this particular slide, and you can see in this in the title, it says high fiber diet means lower breast cancer risk. And so the issue is that when I think as a society, when we think of fiber, we tend to think of constipation. Um, a high fiber diet is indeed associated with less breast cancer. However, only 5% or even less than 5% of the US population meets the daily recommended requirement um, for fiber intake. And the daily requirement for fiber intake is 25 grams for women and 38 grams for men. We've had multiple analyses show that the mean fiber intake in the United States is only 15 grams per day. The bottom line is the more whole food, plant-based diet, the better. Meaning that we have meta-analyses showing that among 700,000 participants, a dose-dependent inverse relationship exists, meaning more fiber intakes means that you're going to reduce your risk. So for every 10 grams of fiber that we take in, we reduce our risk for breast cancer by 7%. What we see here on this slide is really the quintessential optimal fiber diet. It's half the plate exists as fruits and vegetables. And then there is a quarter of plates, which is what we call the starches or the whole grains. And a quarter of the plate is, in fact, the proteins. And the reason why I say this is quintessential is that most people, when they think protein, they think meat, they think animal product or eggs. Um, I took this slide from the American College of Lifestyle Medicine, which is really grounded in kind of the best evidence, and the best evidence shows that when we stay away from animal products, we can increase our health. But on the other hand, we have to enjoy the food we eat. And some of us, including myself, I grew up Italian American. We want to be sort of aware that there can be a plant-forward way to eat that may include some meat or may include some animal products. But this kind of gives you an idea that if we were to eat this way, we probably would be ingesting as much as 40 or 50 grams of fiber per day. But other plant-based diets are sufficient. So if you're feeling overwhelmed and feeling like, wow, that's a lot of vegetables and I don't have time to go to the store, I don't have time to cook chop up all these vegetables every day, and you're not sure where to start, I say, just start with an apple. A daily apple intake has been found to reduce the risk for breast cancer by 21% in case control studies. These are not the most optimally designed studies, but cohort studies also show a reduction. And the mechanism is thought to be actually in the apple peel. That peels in apples, they activate a tumor repressor gene called, it's the mastin that's in the apple peel. And so the more we can activate kind of tumor repression genes, the more we can kind of stave off breast cancer. So I mentioned that I grew up kind of with more in an Italian household. So this is actually a photo of my mother, who is a first generation Italian American. And she very much raised us on the Mediterranean diet. So we had salad at dinner every night. And she was very strict as I grew up in the 70s. No sugary cereals, no TV dinners, no soda pop. That's what we call it in the Midwest, soda pop. And after school, she served me and my friends apples with maybe some peanut butter. And when I went to my friend's house, I got Twizzlers and gummy bears and all sorts of chips and all sorts of fun things. And the thing that was so embarrassing was for Halloween, my mother would give out those little clementines, those orange clementines or small apples, while the rest of the neighborhood was giving out, Snicker bars and all sorts of fun candies. So I learned later in life as I started eating some of those foods and not feeling well that in fact the Mediterranean diet is the diet that I am most comfortable with and feel well with when I live my life day to day. So my mother now is older. She's in her 80s and she lives in independent senior housing. But I've noticed that she was kind of cooking less and going to the restaurant. So we were talking about food and I was asking her about processed food. And her response, of course, is like, no, no, I never eat that ever. And I tell you that within 10 minutes after telling me that, she asked me to go. She was feeling very hungry. She had missed the lunch hour and she asked me to go into the freezer and pull out some sandwich. And lo and behold, I go into the freezer and she's asking me to pull out this box. And I am in total shock that she just says that she didn't eat processed food. And so as we're kind of talking about this, she's telling me, but it's 100% real. And so this is the seductiveness of processed, ultra processed food in our country. And as we went through the ingredients, and I've only circled two here, it's clear that many of the ingredients are ingredients that belong in a chemistry lab and not at the kitchen table or the dining room table. And what was even more concerning is when we look at the labels, we see how much saturated fat is. So there's good fats and bad fats, and saturated fats are not good fats. There's a lot of sodium and sugar. And sugar, we know, increases glucose. Glucose then sends a response of increased insulin. And when we have high insulin in our system, you'll see on the next slide, there is a greater propensity to develop cancer. It's an inflammatory kind of response. And the biggest thing is there's absolutely no fiber whatsoever in this particular sandwich. And we cannot afford, given that we don't eat enough fiber, we really truly cannot afford to be eating excess calories without fiber in our diet. So this is a complicated slide. And really what it's saying is that evidence has shown over and over and over again that healthy plant-based diets, of which Mediterranean is one of them, clearly shows that when we reduce our saturated fats, our trans fat, we increase the fiber, we have a reduction of insulin resistance, we reduce our cancer. What is important to understand in this slide is not only are we reducing our risk for cancer, we are reducing our risk for all-cause mortality. And I point this out because many of us are looking for a magic pill that's going to reduce our breast cancer risk. And the problem is that you can take a pill for 10 years, but if you develop a heart attack and you die of cardiovascular disease, you have not done yourself any favors. So we want to be looking at the evidence that shows what will reduce all-cause mortality because I want to live a healthy life free of cancer, free of heart disease, free of dementia. And the answer is a healthy plant-based diet. So the issue is, well, what's processed, what's not? And even in my own household, I have heard people say anything that's made at home is not processed. And the bottom line is that's not really true. What we want patients to seek and all of us to live better lives, not just patients, because healthcare providers also need to be feeling well as well, is the whole food, the food as it comes, as it's grown off the tree or in the soil. When we break down apples, for example, into applesauce, we are potentially processing it. Potato, for example, I mean, who eats a raw potato? Nobody does. But to understand that when we bake a potato, that's going to be a very different level of processing than when we eat French fries. So it's important that we're bringing cognition, we're bringing our understanding of, okay, at this moment I'm eating a processed food, but then balance that out with food as it comes naturally. So one way to better track what we're actually putting in our bodies is to find a diary, like an app that you can do that. And so tracking can be very helpful. This happens to be a diary that I like, but there are other diaries that will allow you to take pictures of what you eat. But tracking and just kind of noticing what you're putting in your body can be very helpful. We talked about exercise as a way to reduce estrogen levels and reduces your risk for breast cancer. And then alcohol, we talked about that. The alcohol is, in fact, a human breast carcinogen. There's no level that's considered safe to take. It breaks down into a toxic compound that damages the DNA. But if you have to enjoy a little, again, the recommendation is less than 1 drink a day. And then what about sleep? So believe it or not, the proper circadian cycles are really important in terms of reducing the risk of cancer. We have a little tiny gland in our brain called the pineal gland. It produces melatonin, and it's darkness that triggers this pineal gland activation. And it shuts off in the morning as soon as the sun goes off or the lights go on. And melatonin is important because it suppresses cancer growth. So when we have electric lights from the street or from our phones or from TV, we lower the melatonin levels, and they are important in terms of reducing our risk for breast cancer. And so we really want to work on blocking out street light, turning off our phones, and having and honoring that ritual that we need at night to kind of wind down and lower the lights about an hour before we sleep. There is also literature, and this is not as strong of the literature, but literature suggesting that when we are outside and smelling, even just smelling the trees and when seeing the trees, that our natural killer cells will increase not only in number, but in activity. And it's the natural killer cells that help fight cancers. So think about being outdoors. You're reducing your stress. There's less cortisol. There's greater release of the natural killer cells. And the other thing is the social networks, that the more positive relationships we have, the less inflammation. And for the reasons I just stated, lower cortisol, less inflammation can help reduce our risk for breast cancer. And again, the literature isn't quite as strong, but I'm sure there'll be more and more literature forthcoming as we recognize that loneliness and social isolation is an epidemic in our country, and that we need to make greater efforts to stay connected to people that we feel nurtured by. So with that, I will conclude and just to point out that again, breast cancer is common. 1 in 8 women in the United States will develop breast cancer in their lifetime. And it's also important to recognize that there are disparities. And I, as a family physician, I became a family physician because I believe high quality primary care is a right for everybody in our country. And I also believe that as a community, as a state, as a nation, we are only as strong as those who are at the weakest. And so we need to do everything we can to reduce disparities. And I also want to just stress that breast cancer reduction is in our hands. It's not something that requires fancy equipment or huge medical centers. It's something that we can incorporate every day in our lives. And as we are struggling with difficult times right now in the United States and need to show greater kindness, greater graciousness, I say let's start with ourselves. Let's prioritize ourselves. And, eat an apple every day. Just start with that. Eat an apple every day. In terms of exercise, like, can you park a little bit further from work so that you have a slightly longer walk as you walk in? That's good enough. Just start somewhere. Prioritize your sleep and learning to love nature. Just go to a park even. And the other thing is really our friends and our relatives who nurture our soul. Rather than seeing it as an obligation, recognize that when you reach out to them, you connect with them, you're actually reducing your risk of breast cancer and other cancers as well. So these are just some resources for you to check out. I'm happy to answer questions if you want to email me, and I have that on the next slide. And again, I'm just going to ask you what I started with. Knowledge is power, but active applied knowledge is greater power. So, what information from today's talk will you apply to your life? And I thank you, and I will turn the floor over to my colleague, Dr. Stephanie Wang.
Thank you, Dr. Godfrey, for that excellent, excellent talk. And some of the points that Dr. Godfrey mentioned, I will also highlight again in my talk as well. Thank you to Dr. Mach and also Dr. Bell for the invitation for me to be here today to present. And thank you again to Dr. Godfrey for that excellent talk. My name is Stephanie Wang. I am a licensed acupuncturist in naturopathic medicine with the Osher Center for Integrative Health at the University of Washington. And so today I'll be giving a talk, a really brief overview of integrative framework for survivorships. So now we kind of go from prevention, where Dr. Godfrey has give us a really good talk on, to now more of a survivorship. So a different aspect of a patient's cancer journey. So I don't have any financial conflict of interest to disclose. And so when it comes to talks like this, I like to be a little bit more interactive. And so if you guys don't mind, for people that are sort of live right now, what you can do is you can take out your phone and turn on the camera function and then just scan that QR code. And then there will be a question that pop up for you. Or if you are using something else, you can enter the website slido.com and enter this question number. And for people that are watching this later on, you can also think about these questions as you're watching this. Okay. And so the question that I have for the group who are participating is that when you hear the word survivorship, like what comes up for you? And I'll just give everyone probably like a minute or so. And what's going to happen is that as you enter the question, enter your answer, things are going to pop up. Okay. So thing like words will pop up and then we'll have kind of a word cloud um, going. And so we'll kind of just see and yep, and I'm seeing a lot of good answers. And also for people, again, that are participating later on, you can also think about if any of these resonates with you and how your answers are similar or different from everyone else. Um, and unfortunately, just a reminder for the people watching later, you won't be able to enter later on. So great. We're seeing a lot of good words here when it comes to like family, resilience, support group, warrior, you made it through adversity. Yeah, that's right. Yeah, avoiding that, thriving, a really good important part. Care. Yeah, and illnesses, resilience and pain. Yeah, these are very, very common sort of vocabularies around survivorships. Okay, I'm just gonna give illness. Yep. Okay, great. Oh, people are still participating. Oh, probably. Journey. Great. Okay. Okay, that's a really, really good start. And then we'll definitely talk about that. And journey is a big part when it comes to survivorship. So thank you all for participating for that. Okay, so then let me make sure. Great. So this is kind of a roadmap of today's talk. We will have a brief overview of breast cancer survivorship epidemiology, so the statistics around that. And then we'll get into definitions of cancer survivorship and what that means and how it has evolved. And then we'll discuss different perspectives on survivorship care models and the different lenses that it brings. And also then we'll launch into an understanding about integrative whole person care and also introduce this sort of anti-cancer mnemonic that I came up with a few years ago for individualized care. So, as Dr. Godfrey already mentioned, when it comes to breast cancer epidemiology, which is a little bit different when it comes to incidence, this particularly is about survivorships. And so breast cancer is the most common cancer among women, with a really high survival rate now approaching 92% in the US and similar rates of in other developed countries. So right now in the US, breast cancer accounts for 4 in 10 female cancer survivors in the US. So that translates into roughly about 4.3 million breast cancer survivors in the US as of January 1st, 2025. And that's a significant amount of women that we're talking about here. And as Dr. Godfrey has mentioned, the mortality has steadily sort of decreased since 1989, due in part largely to our early screening, early detections, and also increased awareness and educations, as well as better treatments as well. And however, when you look at our statistics, what we have found is that with these advancements, there are women that are living longer with breast cancer. So you can see we're looking at about two-thirds, like 67% of women that have been diagnosed with breast cancer who are age 65 or older. And so that's a significant amount of populations there. And in addition, people are living longer with breast cancer as well. So according to this data coming out from 2025, about 50% of women that have been diagnosed with breast cancer have lived at least 10 or more years since the time of diagnosis, and which is a significant improvement compared to before. And what that means is that we are having longer survivor rates, but it also means that we need more specific, dedicated strategies to manage a lot of these long-term effects from treatments for our breast cancer, and also to support better quality of life for all these survivors as well. And so, what does survivorship actually means? So, historically, survivorship was only meant for the periods of time after active treatments, such as surgeries, radiations, and chemotherapy. However, back in 2006, the Institute of Medicine has expanded this definition to address the long-term needs of cancer survivors. And currently, the National Cancer Institute sort of defines cancer survivorship as the health and well-being of a person with cancer from the time of their diagnosis until the end of life. And as you can see, that expansion sort of really makes survivorship a very inclusive word, but also means that we're talking about a large populations of individuals now, because as soon as you have a diagnosis of any cancer, you are considered a survivor. Um, what I love about this definitions is the aspect of health and well-being that they have included. But we know that sometimes when it comes to addressing the health and the well-being, there's a lot of aspect that we're lacking in providing support for survivors in those arenas. And additionally, survivors also encompasses sort of family members, caregivers, and friends of the patients. And that is but to me, that sort of indicates the importance of community and when it comes to survivorships. When patients go through cancer treatments and starting on the cancer journey, it's not only them that's get impacted, but the people around them gets impacted as well. And so then the survivorship also includes these individuals to demonstrate sort of the importance of community that way. So then, because survivorship is such a long and dynamic process, like this idea of like season of survivorship sort of came up. So this was first proposed and introduced by Dr. Fitzhugh Mullen in 1985 when he himself was diagnosed with a rare form of testicular cancer and then he was undergoing treatment. And he initially had proposed only three phases or three seasons of survivorship, which is the acute, the extended, and then the permanent. But this model of sort of clinical look on survivorship has been adapted and expanded to this current model here. And so when we are looking at survivorship more from a clinical setting, there are sort of for 4 or 5 different categories here. So initially, there is this acute season, and that is at the time of diagnosis, at the onset of the time of diagnosis to the completion of your active treatments, such as radiations, surgeries, and chemotherapy. That is what defined as the acute season of survivorship. And then as patient completes their treatments, they move on to what this sort of transitional period. And this transitional period is quite sort of fluid as well. The transitional period is usually dominated by this idea of like we're sort of moving forward and into this new normal as patients sort of completes their treatment. And then that transition is transitioned to more of an extended survivorship, which is sort of average wise, I think commonly think about as sort of 5 years, sort of from the time of diagnosis. And that extended survivorship can look very different for different individual. Some patients, depending on their disease, they can be in sort of the no evidence of disease phase of the extended survivorship, whereas some group of population, they sort of enter into this extended survivorship where they still have maintained remissions, but then they are on some level of therapy as they are continuing to seek care that way. But then it sort of heads into what we also call like chronic survivorships. And chronic survivorship is this growing group of survivors where they may have either partial or complete remission from their disease, or they're still receiving treatments for their ongoing recurrent diseases. And a good example of chronic survivorship as it pertains to breast cancer patients is we're seeing a large group of metastatic breast cancer patients that are sort of living with their disease, but they still have ongoing treatments from their oncology care teams that way. And then that sort of that expansions of time is quite long where they're living with this disease. And so then moving on from the extended survivorship slash the chronic survivorships, then we kind of move on to beyond that 5 year period, this permanent survivorship. Permanent survivorship is also a very mixed group of individuals here. There are subsets of individual where they continue to demonstrate they don't have evidence of disease, or sometimes we call them cancer-free. But then there are also permanent survivorships where they could um, still suffer from sort of long-term and effects from their treatment. So very commonly we see this in like, for instance, like peripheral neuropathy from their chemotherapy, or this ongoing fatigue that they have experienced, or sort of cognitive impairment from their treatment as well, where they're still struggling with their treatments and the side effects from their treatments. And certainly there are groups where they may develop second cancers, second independent different cancers, or secondary cancers that potentially may be a consequences of their treatment as well. So it's a very mixed group of individuals that way. And so when when we're looking at it from a clinical lens there, I also like to look at it from sort of more of a humanistic lens as well. So each of these phases are oftentimes dominated by certain sort of themes that are very common among survivors. So when it comes to acute phase at the time of diagnosis and early, with treatments, there's a lot of anxiety and fear from the survivors themselves, and also their caregivers and the friends around them. There's a lot of anxiety and fear about the treatments and what the process is going to look like, as well as just the amount of information that they receive in trying to tease out what is the best course of actions for the survivors. And so there's a lot of sort of fears and anxiety in terms of starting this new path and this new journey. And as patients move sort of into the transitional phase, this idea of like this new normal, what does that new normal look like? That I hear that clinically a lot with patients, like, well, I guess now this is just what I'm dealing with, and this kind of new normal that I am having to face and live with. And that sort of emotion sort of carries throughout into sort of the extended periods of time. A lot of times, the fear of recurrence is a very common and it's longitudinal feelings that patients often experience throughout the entire durations of their survivorships. And that extended periods is often met with a lot of dealing with long-term effects as well, and returning back to work, and how does that look like living with some of the side effects that way. And again, a lot of these are really overlapping sort of themes around. So the same thing with the fear of recurrence and dealing with long-term effects. The permanent group and also the chronic survivorship also experience that. But there's a lot of sort of like, still going to treatment, but I still have to work, but I don't feel like I have the stamina that I had before. I'm always tired. And this neuropathy is making work a little bit more challenging and more difficult. So they face a lot of sort of these practical level of challenges that way. And then if patients are moving on to more end of life, there are other considerations that are more like palliative care and spiritual considerations that may have. And so while that is a one lens of looking at survivorship, the other lens that I actually like to look at, and it's a little bit more, I think, practical sense, is these what I call impact domains of survivorships. So a lot of times when it comes to survivorship, there is a lot of emphasis and focus on the physical symptoms from their care team. And so that's, the oncologist trying to make sure like you're up to date on your all of your uh, imagings, and then are you doing okay with some of your symptoms for like joint pain, for instance, on aromatase inhibitors, for instance, or screening for bone health and bone density. So a lot of emphasis is on the physical body, but we know that survivors suffers from various aspects as they're receiving treatment. So a lot of impact can be happening to the social and the relational aspect, as well as the psychological and the mental when it comes to anxiety, depression as well. And we know that that can bleed and sort of impact and influence a lot of the spiritual and also existential aspect of, self-esteem in an image changes with, when you have breast surgeries and the breast removal, there could be a lot of emotions around that too. And also the practical aspect, like I mentioned, sort of returning to work is a pretty big um, components for a lot of patients are often overlooked, in my opinion. And also, there's also this financial considerations. We know that treatments are not cheap in this country, and so there could be a lot of impact with that as patients are continuing on or with their treatments this way. And however, while these are sort of multiple ways of looking at the survivorship, what I really like is this idea of a survivorship iceberg. To me, the iceberg analogy is much more patient-centered when we're looking at how survivorships impact patients. And this is not a new concept, so it's not a very common sort of a well-known concept, but I like the visual of it. I think it's a really good visual analogy for when we're talking about survivorships in my experience with patients. So a lot of times there's a lot of focus around the physical challenges, so which is often focused on the physical symptoms and the physical conditions. So for breast cancer patients, a lot of times it's this lymphedema you can see when someone's wearing their compression and sleeves, where there's a lot of focus on sort of their bone density and bone health, or cardiotoxicities, screening from their treatments as well. Also, maybe like the hair is starting to grow back. So visually, you can see that someone is improving or they're recovering well. And from a medical standpoint, there's also a lot of emphasis on surveillance for recurrence and management of comorbidities and screening for secondary cancers and follow-up. So there's a lot of emphasis on that. But what we have found is that what patients often struggle with is these hidden burns, so these under the ocean level icebergs. And so these are often the unmet needs of survivors. So data have shown is that there are some level of discrepancy when it comes to what the patients and the survivors would like to address versus what their care teams are sort of addressing and prioritizing in their care. And so I would say that a lot of these unmet needs of the survivors are the things that are more impactful on their quality of life. And we know that when you sort of remember kind of looking at the impact domains or that graph, what studies have shown is that during first year after the end of the treatment, most survivors will have at least one, if not more, of those domains of unmet needs that they have that they experience. Um, and potentially that are not quite addressed by their care team. And so the data from some of the cohort studies it shows that a lot of these hidden burdens that are potentially not addressed at the top of the list for the caregivers are things like fatigue, sexual health problems, sleep, anxiety and depressions, and then joint pain, neuropathies, or cognitive issues. And these are a lot of symptoms and burdens that are shared across for a lot of these survivors, but might not necessarily be addressed right off the bat. And so a lot of times patients feel like they are not necessarily sort of looked at and addressed in those considerations. And so we also know that emotional and social sort of recovery often lacks physical recovery. And I like to equate this to more of sort of like a PTSD sort of presentations because there's a lot of emphasis while patients are undergoing active treatments around the tumors, around the disease. And then we don't necessarily have the time to address a lot of the emotional and the social needs. And so now that the active treatment is completed and we have more time to focus on the other aspect, a lot of the times I have seen a lot of patients where there's a lot of emotional processing that needs to happen for them. And as we know that cognitive issues do present and do impact return to work, and that can really also impact to social functioning and also relational difficulties, and to a certain extent also self-esteem as well. And so how I think about integrative care and integrative sort of survivorship and what I can sort of help address the hidden sort of burdens of these patients is what I call the sort of whole person care. And so we know that conventional care is very, very good at targeting the tumor. The surgeries, the chemotherapy, the radiation, the targeted therapy, immunotherapy. We have a lot of tools, and the oncologists have a lot of tools in addressing the tumor. But unfortunately, these treatment, while they're really good at targeting the tumors, they might not necessarily sort of be good at addressing the rest of our cells. And that's where integrative medicine can be really, really helpful in this case, is that we have the opportunities and the tools to help address things like Dr. Godfrey has mentioned. So diet and maybe exercise, stress reduction, sleep, emotional support, spiritual support, and the immune support, and sort of minimizing sort of the carcinogens that way, and potentially having discussions around supplements if or when if it's indicated that way. And so that's where integrative health is sort of the best of both worlds, where when the patients sort of receive integrative care, we have a lot of emphasis on the self and less and when I wouldn't necessarily say less, but it's just sort of, it has more emphasis on the self and allowing conventional care to be doing what they're good at, which is targeting the tumors that way. And so Dr. Godfrey has done a really good job in terms of showing the evidence around these modifiable risk reductions sort of toolkits. And that sort of is applicable throughout active treatments as well as definitely into survivorships. And so I created this sort of anti-cancer mnemonic so a couple years ago. And a lot of the ideas is the same. So we want to sort of avoid our carcinogens and we want to focus on nutrition that way and then really consider the appropriate treatments during the active treatment portions of it and really focus on things like exercise to help with immunity, to help fight off infections and also potentially with cancer as well. And also reprioritizing, what your goals and the plans and the people around you. And this is what I call like the cancel to fit with the mnemonic. But sort of the journey of survivorship sort of really changes an individual. And so a lot of times when patients get a diagnosis of cancer, it really sort of help and reframe and shift their goals. And so really focusing on sort of pruning the things that you don't need in your life is quite important that way. And so then also that sort of moving on to sort of adjusting to the reprioritized goals that way in sort of helping to really focus on yourself and getting healthy. And also the emphasis on nature as well, which is really important, as Dr. Godfrey has mentioned. And also things like confidence. So building the confidence in your body and also in the treatments as well. A lot of times I've talked to patients and certain women do have some changes in their self-esteem. And this also sort of pertains to like sexual health as well when it comes to, in the survivorship, because of the treatments, their sexual health is very different from pre-treatments. And so having sort of reconfidence in the body and help supporting women that way, I think it's really critical. And so also continuing to emphasize exercise and sleep, and then the spiritual and then the social support that way. And so these are kind of a really good framework for modifiable things that are quite actionable that everybody can do. And so when it comes to integrative healthcare, so when I have patients come in to sort of discuss sort of survivorship care, this is a really helpful framework because each patient will have different needs when it comes to integrative care. And that's why it's a really good individualized care that way. And using this framework, we can kind of figure out what somebody is in need of and need more support of, and help address their overall health. And so in summary, survivorship is a really broad and dynamic process and time frame in a person's life, and that there are different lenses and perspective on survivorship care models. So there is sort of the seasons of survivorship that looks a little bit more on like the clinical aspect, but then there are sort of the impact domains because that are more of the practical sense of like how is the treatments and how is the survivors are living. And then the iceberg model where I think it's more patient oriented in terms of looking at how survivorship and how we can help support survivors that way. And then when it comes to integrated whole person care, it really is about addressing individualized unmet needs of the survivor. So as we go through the whether it's the integrated whole person care sort of graphic or the anti-cancer mnemonic, those are ways to help us sort of address what each patient needs. So I think This is kind of my talk, so thank you for everyone for attention and also participations for the word cloud questions.
Thank you so much, Stephanie. Let's see, Dr. Godfrey is coming on. Great. So we have a couple of questions to ask both of our speakers here, and hopefully these will address some of the questions that came up for you. And thank you both very much for your informative talks. And I'm inspired for this first question based on Dr. Godfrey, your list, and Dr. Wang, your mnemonic. I really like that anti-cancer mnemonic, and there's a lot of overlap. And so the question is, what is the interventions that you have found most helpful for both survivorship and prevention? So, you mentioned a lot of things, and maybe it is all of those things, but within those things that you have mentioned, or other interventions, what are the things that you find to be the most useful? And we'll start with you, Dr. Wang.
So I think for me, Um, I'm gonna be a little biased because as an acupuncturist, I'm always gonna say acupuncture is a really good intervention. And so, because I think acupuncture is it's a whole set of health system that I think can be applicable for, so not just alleviating, for instance, aromatase inhibitor joint pain, which is a big part, or the hot flashes from, let's say, tamoxifens as well. And so, but it can also be helpful for addressing a lot of the mental health considerations. So I think acupuncture as a is a really good tool for me in terms of as addressing multiple domains for the patients. The other one that I think is quite that I found particularly helpful, but I would say more challenging is actually exercise, really incorporating and encouraging people to move more. I think right now in our society, movement is on the lower end, and so really encouraging movement is can be a very useful in terms of reducing sort of side effects and long-term um, effects of the treatments. But also, I think exercise is a really good in sort of lowering sort of all-cause mortality, not just for cancer, but for cardiovascular disease as well. But I would say that the implementation sometimes can be more difficult. And that's also speaking personal experience, right? Like getting me to exercise sort of every day can be challenging. And so I would say that exercise does cover a lot and it is easier said than done, but I do find that exercise can be very, very helpful in targeting and addressing a lot of those domains that way.
Great. Thank you, Dr. Godfrey.
Yeah, I mean, I agree with Dr. Wang that that like lifestyle medicine is six pillars, but it really is a hexagon that every part of lifestyle medicine, what you're putting in your body, the exercise, the sleep, the connection, the stress reduction, it all goes together. I think women in particular have a propensity to kind of suddenly have added weight in the postmenopausal stage, and so I agree that exercise is really important, but it's also important to remember the integration of all of the pillars. I see a lot of sleep disturbance in my practice. And sleep, when one does not rest well, it's very difficult to really be cautious about what we're putting into our bodies, and it's hard to work in your exercise. So sometimes it's the sleep that we really need to work on.
Mhm. Yeah, I would agree. Yeah.
Great, thanks. And I'll just add that with all of these lifestyle modification factors, there is always the issue of how to make change. And Dr. Godfrey mentioned when she was just talking about noticing about breast cancer, signs of breast cancer, that awareness and awareness of our body is a very helpful tool for helping us to notice what we are doing and whether or not we notice that those things will be things that are going to be things that will help us to get where we want to be in our health. And with regards to exercise, I always say to people to look at your week and think about when and where you might get your exercise. Because often, if you think you intend to do it with good intentions, and
Hmm.
then it's the first thing that gets put aside.
Yeah.
So there are lots of different techniques of how to make these changes, but it all starts with the awareness and paying attention.
Yeah. I think with the exercise, I've lately been telling patients to do like what I call exercise snack. So it's like a really short chunk that they can do. It's like very short, even like 5 minutes. If you just either have a little break in between work or in between classes or wherever you are. And so I call them exercise snack, just like people can like, oh, it's just it doesn't have to be you set aside like 30 or an hour. And I think that's usually where people get overwhelmed. It's like, how do I find the time? But then exercise do kind of add up. And so these short bursts or like short snacks are a great way to incorporate into people's sort of routine that way.
Great. And Dr. Maj, I think, has a comment he wants to make about exercise.
Oh, sure. Yes, thank you. I wasn't intending to talk about this, but thank you for including me. And I think Dr. Wang actually added that I like the idea of exercise snacks. And this is what I do in my practice. As you know, I'm a physician, I see patients, but what I do between seeing patients, I usually make like 30 seconds, 45 seconds, or even 1 minute between patients. I go to one of the exam rooms and I do kind of like I hop, I jump like up and down for about, I don't know, 50 to 100. And I repeat it like 4 or 5 times during the day. So by the end of the day, I have done like this 400 times, I guess. So I know that it's kind of like adding into it as we go to do our best. One thing that Dr. Godfrey mentioned here regarding sleep and the importance of the sleep. Dr. Bell and I did a presentation, I think about a week ago in Sedona, and that was Interview of Women's Health. And one of the conversation was sleep. What I wanted to mention here is that as we get older, one of the neurotransmitters in our body declines, and that is GABA. It's called GABA, and GABA is very important for sleep. And one of the ways to increase GABA in the body is regular exercise. So we go back again to the movement and exercise that can naturally help us with our sleep. So thank you for including me here.
Thanks. Great. Um, the next question is there's a lot out there now about people needing to eat a tremendous amount of protein and very high protein diets. So do either of you have comments about that? We'll start with Dr. Godfrey.
Yeah, I mean, there is a huge craze around protein, and I think there is a misguided direction that's going on kind of in the popular press about protein. Protein is metabolized primarily in the liver, and when we have excess protein, the keto acids are actually if it's not used for energy because we're not exercising enough, it's just going to be turned into glucose. And of course, we know when glucose goes up, um, insulin creeps in, and in the end, we end up storing fat. And so that is not in any way helpful to our health and well-being. In addition, protein is broken down into uric acid, which gets excreted through the kidneys, and of course raises our risk for gout and can be pretty hard over time in the kidneys. So we just want to be aware that excess protein can lead to metabolic disturbances, lead to greater incidence of diabetes, cardiovascular disease, and what we call non-alcoholic liver disease. So just want to make that clear that fiber is the answer to preventing all these diseases, not protein.
I
Dr.
would,
Wang, you wanna-
yeah, I would in agreement with that. I don't think we're necessarily under protein, but I think we're more under fiber. I think that is kind of the general when it comes to the sort of dietary recommendations that I've seen. And so, and it's harder, I think, to increase fiber than to increase protein, in my opinion. And so, but in general, I think what we want is we want more fiber, which then I think if you're eating more fiber, you naturally, we can only eat so much. And so that protein count can definitely be better managed that way. So, but I do think that it's more important to increase fiber.
and I would add that plant-based proteins have fiber in them. And so things like legumes and nuts and whole soy products, not the processed stuff, are a source of fiber as well as our whole grains and vegetables. Okay, and this is sort of a hotter topic. We talked about sleep and melatonin and endogenous, meaning the melatonin that our own body makes, um, helping us with cancer risk reduction. So what about taking supplemental melatonin? Dr. Godfrey, do you want to start with that?
Yeah, so I had looked into, you know, sort of what is the science around taking supplemental melatonin if we're not really getting very good night's sleep. And unfortunately, taking supplemental melatonin as a pill or injection, it does not reduce your risk of breast cancer. There's really no evidence around this. There's some evidence, maybe for postmenopausal women, that it might reduce breast cancer risk, but that really has not been held up in repeat studies. And so further trials are needed in terms of taking melatonin and reducing your risk for breast cancer.
Great. And Dr. Wang, do you want to comment about the use of melatonin in treatment and survivorship?
Yeah, I think there are sort of preclinical data to suggest that melatonin has sort of anti-proliferative effect and also like and also like pro-apoptotic effect from it. And so in sort of in those settings, it seems like melatonin can be used adjunctively in sort of in an active treatment or also in like survivorship settings or when patients have completed treatments. But I feel like in general, those we haven't have any sort of robust clinical studies to show that it's actually effective and or adds to an overall survival of an individual. However, I'd say that it's the melatonin can, it's helping for the sleep that way. And so if we can help support patients in their sleep, I think that will be more impactful in terms of their quality of life that way. And also maybe in the setting for prevention, I think more helpful in prevention in that setting. So
Great. And I would add that the dose of melatonin that has been studied for for use while people are getting their cancer treatment, as well as some people for survivorship, is a much higher dose than we use just to aid us with sleep. And so this is something that I certainly would recommend working with an integrative oncologist or integrative practitioner if that is something you're thinking about using those high doses and whether or not it would be at all applicable for you. Um, let's see. I see that Carolyn has sent a message to everyone, so just direct your attention to that with thanks, and with it is a QR code, as I mentioned about um, our donation. So that's on there as well. I think we have time for one more question. And I would say the question is, what are the aspects about both Dr. Wang, what you mentioned about the different domains of survivorship, and Dr. Godfrey, I think that you addressed this a fair amount as what in conventional medicine is missing. But what do you feel the things are that are most overlooked that people might not hear in their conventional care with regards to survivorship and prevention? So, Dr. Wang, do you want to start?
yeah, sure. I think when it comes to sort of the often more overlooked aspect, that I think relational is a really huge one, and I think there's more awareness around sexual health now. Before the longest time, I think sexual health wellness was sort of it wasn't in sort of people sort of conscious to talk about it. But I think relational one is a really big one when it comes to sort of survivors and as they are either sort of moving on and moving into sort of this new normal that they have and what their relationships like with their loved ones and caregivers. I think it's a very unique dynamic, and I feel like that sometimes that might not be sort of addressed because a lot of times from the outside, survivors look like they are improving. They look like they're healthier. They look like they're physically getting better. But I think emotionally there's still a lot of processing that needs to happen. But they might not necessarily have the opportunity to process what with let's say a licensed professional that way. And so sometimes with the conversations that I have with patients, there's a lot of sort of just social connection things that we need to talk about. Because I think within the last, I would say 5, 10 years, there's more awareness around sleep and around like mental health. And so that's why I'm kind of not mentioning that because it is in the guidelines now for ASCO, so American Society of Clinical Oncology. They have specific guidelines when it comes to survivorships on things like anxiety, depression, sleep, and fatigue, and even like peripheral neuropathy as well. So there's more awareness to address those things. But I think when it comes to like relational and support that way, it's not it's in the back of people's mind, but I don't think it's sort of upfront that people are talking about it.
Dr. Godfrey, you want to add?
Yeah, I mean, I think from my perspective, healthcare providers are really not, and physicians in particular, are really not emphasizing the importance of nutrition and what we're putting in our body. I think there is a real lack of quality teaching as it relates to food. Food is health, food is medicine in medical school, and research is repeatedly showing that physicians often don't get the training that they need around what we eat and health and use their own personal experiences, which is often misguided. I think what's so challenging for patients is there's so much information about diets that come out, the different diets that come into play and say this is the way to lose weight, and then suddenly time goes by, or the weight loss medications, and they're all the rage for a few years, and then they fall out. And so a lot of conflicting information, and a lot of the information around nutrition studies and even our guidelines in our federal government are met with conflicts of interest. And I think it's really important for people to understand that it's the tobacco country companies that are behind much of the ultra processed food that unfortunately even my mother has been inclined to eat, and to recognize that they are sometimes funding some of these nutrition studies, and are involved in the federal guidelines around sort of healthy eating as well. So some conflicts of interest there. So getting good information, real information from your healthcare provider really starts with the education in the health professional schools. So that's where I'm turning my attention.
Right. And at the Osher Center and our Department of Education, we are also making great efforts to educate our colleagues in medicine around the foundations of integrative nutrition and what's called culinary medicine, so that we can also give people some ideas, specific ideas of things that they can eat or how they put how they put that information into action. So, with that, I think we won't try for another question because then we'll go over, and I want to respect everybody's time. I do want to let you know that we do have one more online Integrative Women's Health educational event happening in December that will focus on mental health, specific for women, and invite all of you to register for that and join us live if you can. And if not, to know that all of these are recorded and put on our website. And if you register, you get the recordings sooner than when they get posted. So again, Dr. Stephanie Wang and Dr. Emily Godfrey, thank you so much for your wisdom and your time and your information. And to those of you still listening, thank you very much for your time and your attention. Dr. Maj, thank you very much for being our leader and guide. And I also want to thank Carolyn Kim, who puts all of this together and does a great job with everything. When you send in an email with a question, she's the one who's navigating all that. And we're very, very grateful for all of the support that she gives us in making this a reality. And I hope that you have a lovely rest of your day. And thank you again.
Thank you, everyone.
Bye.